Thank you very much, Dr. Rob, and indeed it's a pleasure, my third time in Doha. Thanks to Professor Khan and Professor Nebo for organizing. I always enjoy meeting my colleagues here, Professor Nabil and Javier as well, and as well as my colleagues outside radiology. So it's a real pleasure. And this winter you're having here, it's okay by me, all right? Nice and warm in my opinion. So we're going to talk about the Vancouver Olympics, but we're not going to talk about the events, which are winter related. Of course, that is not all that relevant. However, the staging of a big athletic event carries with it many similar themes, and those are what we're going to explore today. So here's what I hope to accomplish. We're going to talk about the lessons that our team learned at running really a sporting event of this magnitude, especially with respect to organization and integration. We're going to understand the emerging sports consultancy roles. I really believe that there's a new subspecialty in radiology called sports imaging, and it's becoming more and more discrete. So we're going to talk about that and the role we play amongst all of you in the team that looks after the athlete. And then finally, just talk about the demand on radiologists. How are we going to manage this new role amongst all the other requirements that we have as professionals, with an emphasis again on the 2010 games. And hopefully some of these points will apply to Aspetar. I really think that Aspetar is probably one of the best examples of an Olympics-like kind of setup in terms of how the athlete is cared for. But hopefully there will be some things of interest. And of course, I'm going to do this all from a Canadian perspective. This says, "You seem familiar yet somehow strange. Are you by any chance Canadian?" That's an American cartoon. They seem to think we're just a little different. So some of that will come out in the presentation as well. So let's get on with it. It's kind of like the old expression, bringing coals to Newcastle. Talking about elite sporting events in Doha. I mean, you've had so many events over the years, beginning with the 06 Asian Games, responsible for some of the infrastructure around here, leading to most recently your handball championships, just finished the World Championships. I know you've got the Qatar Total Open right now. In fact, I saw Dr. Adam Weir and some of his colleagues in the newspaper just a couple of days ago being highlighted for their care of the athletes. I understand there may be another application to become a Summer Olympics host city, which is very exciting. And of course, arguably even more exciting is the FIFA World Cup, which is in 2022, as you all know. So obviously you had a lot of experience in organizing big events from the medical perspective, and I'm hoping that our experience here will be able to share some of the most important points. Well, in order to find out the role that imaging plays in management of the athlete, you don't have to look very far. You could open the sports page, and you'll often see a headline like this: Shaquille O'Neal out for 2 weeks in the NBA after an MRI on his left hip. These headlines are virtually every week. But there's got to be better data than that to show the role that radiologist plays, rather than just headlines in the sports page. So here's some of that information. So from 1996 to 2005 in the US, using their database, there was an increase in MSK MRI exams of almost 350%, and of MSK ultrasound exams of 200%. A lot more MSK cross-sectional imaging exams are being done. We look at another metric, the number of imaging studies performed at a world-class event like the Olympics. So in Torino versus Salt Lake City was 2002, Torino was 2006. We saw a 45% increase in imaging studies performed between those two games. And the imaging center at the Olympics, winter or summer, is now the second busiest department of all the Olympic polyclinics. The busiest being, anybody know? Dentistry. Go figure. Dentistry is the most busy clinic, and that's actually for public health reasons as well as anything else. So other examples of why radiology and sports imaging are really advancing so much. Clinicians are under pressure. You all feel this in deciding when it's safe in the athlete and team's best interest, particularly athlete, to return to play. Return to play decisions are very complicated. Radiologists play but a role in those decisions. It's a decision made by the team, but imaging does play a role. For example, there's a number of studies. I'll highlight this one. 38 professional American football players. They looked at a retrospective study of hamstring tears, something you all are very familiar with European football. And what they showed was if the tear is less than half the cross-sectional area of the muscle, and it only involves a single muscle group, and there's no retraction of the musculotendinous junction, then you're going to miss less than 2 games, which in the NFL is about 2 to 3 weeks. So that's useful data. I mean, you want to get the athlete back. The team is pressuring you because they're very highly paid. They may be a superstar. They could use their skill. On the other hand, we don't want to bring them back too early so that they re-injure. Very complicated decisions. So here's an example. Some imaging exams from an athlete, in this case, an American football player. This is an axial image through the pelvis. This is the front, this is the back. Patient's right, patient's left, as if we're looking from the foot of the bed up at the patient, for those of you who aren't familiar with MRIs. The green arrow shows you the common hamstring origin arising off the ischial tuberosity seen right here. This is a fluid-sensitive, fat-suppressed sequence in which edema or tearing is bright white. You can see there's a tear of the common extensor origin, and this one is from the side. There's the hip joint, the front, the back, the ischial tuberosity, and there is this tear involving the aponeurosis. So using the information we just reviewed, this involves more than one tendon because it's the common tendinous origin of the hamstrings. And it involves more than half its cross-sectional area. So this patient would be expected to be out for longer than 3 weeks. Again, bearing in mind the clinical presentation, because that's really, really important too. But this is how studies can help in imaging make these decisions. And we need a lot more of these studies to be able to make really evidence-based decisions. Okay, so let's look at some of the experience from Salt Lake Olympics and Torino Winter Olympics to see what we can learn. I think that's one of the themes today, is that I found when I looked after the games that the data that came from prior games wasn't as detailed as I would have liked. So I found myself kind of reinventing things as director of imaging at the games, when really there should have been more information there from prior events. Nonetheless, here's some of the information I did receive. So at Salt Lake City in 2002, they did almost 400 imaging exams. You can see the breakdown there. Note in particular that they did quite a few MRIs, not that many ultrasounds. That sounds like the North American way of doing things. And very few CTs, 4 CTs in total. What my colleague Julia Crimmen at Salt Lake wrote up, and this is great that she wrote it up, was that the knee was the most commonly injured joint, and the most common injury within the knee was an ACL tear. Not surprising, given the sort of athletics we're talking about. Foot and ankle were second. A lot of that's because of snowboarding, and the highest rates of injuries were snowboarding and alpine skiing. But the data wasn't great because it didn't take into account training events. It just took into account the actual final heats, the competition itself. So anyway, interesting information, and this helps us plan what to do as we put together schedules and buy imaging equipment, or at least lease it, and plan staffing. Well, here's the setup for Torino. And a couple of things I want to emphasize here. First off, like any big world sporting event, there are multiple venues. So for your World Handball, I understand there were 3 venues. For the World Cup, there might be 8 or more venues. For the Olympics, there's always multiple venues. In the summertime, it's equestrian and yachting, which are off-site. For winter sports, it's actually quite a nightmare. What you've got is a place here, Baronicchia, which was snowboarding, and then way over here, where alpine skiing was where the MRI unit was. So, imagine these alpine roads you've got to navigate in order to get to these various sites. So winter adds an additional dimension of weather, but any big event has this distributed model of different sites, which makes the medical care more challenging. Here's the the time frame of the imaging studies done at Torino. Now recall they did 390 imaging tests in Salt Lake City, and 4 years later we're doing 567. Broken down differently, partly because of the way athletes are imaged, and indeed patients in Europe. Lots of x-rays still, many more ultrasounds, 80, and many fewer MRIs. So again, good to know the volumes, good to know how they handle the volumes, and they had different sites that were able to do the imaging tests as close as possible to the athlete, a point I'll emphasize in just a minute. In terms of what sort of things you see, well, as you know, you see a lot of different stuff. Some of it is not all that exciting, like this. This is a big hill Nordic ski jumper, lands on his elbow and ends up with this. There's a plain x-ray. You can see they have an intra-articular vertically oriented fracture through the radial head, which is going to need to be addressed. So pretty routine stuff. Even more routine, even great athletes fall on their butt. Okay, here's a slalom skier that did just that, and he ended up with a really sore hematoma, a gluteal hematoma, which we imaged here. This ultrasound is not very pretty, but this is the hematoma in here, and we can watch this and make sure it resolves okay. So it's some imaging is pretty mundane. Some of it is not, however. And one of the things that we faced in the Winter Olympics is the increasing risk of the sliding centers and injuries associated with it. So we knew that in Torino, here's a picture of a two-man luge, that there was some pretty serious trauma. This is a reconstructed CT scan. This is the front of the patient, the back of the patient. You can see there's a fracture dislocation at the mid-thoracic spine. What follows is an MRI, which just demonstrated the narrowing of the spinal canal. And in fact, this patient was paraplegic and went on to internal fixation, as you can see by these interpedicular screws and twin DC rods. So big time trauma. It turns out, in Vancouver, we had a luge track that was the fastest ever. The fastest speed clocked on it was 155 kilometers an hour. It turns out it's not unusual for lugers to lose consciousness briefly on some of the corners where the G-forces are just extreme. So this is a very high-risk sport. Now in Vancouver, we had the unfortunate event of actually a luger dying on the first day of the opening ceremonies due to a severe accident, clocked at about 140 kilometers an hour. So again, these are lessons learned. One has to be really, really careful. And when you plan your athletic care, you've got to be aware that in the winter, with all this sliding, whether it's on the alpine venues or at the sliding center, there is capacity for high-speed trauma. You need to be able to account for that and treat the athlete. Okay, so let's look at our 2010 Olympics and talk a little bit about what we saw and maybe some of the mistakes we made. It's a big event. That we all know. 86 countries for the Olympics, 42 for the Paralympic Games. I won't really have time to talk about the Paralympics today, but it was really an amazing event and very, very inspiring. You could see that the number of volunteers, 27,000 volunteers. We have to treat those people as well if they run into trouble. But look at the number of estimated television viewers, 3 billion. So you're on the world stage as an organization, and there's a lot of pressure to have things go well, for sure. More importantly, to look after these athletes as optimally as possible. So we had this information from prior games. Not enough information, but we did have some information. What were we thinking? How do we use the information to plan? Well, we thought that if we saw that same 45% increase of imaging volume, if indeed this sports imaging subspecialty is really that much on fire, then we should see around 800 studies. So that would be the equivalent of a 45% increase over Torino. Having seen what we saw at Torino with respect to the luge center and knowing what we knew about our track, we wanted to have CT for multi-trauma, spine injury included, and MR both at Whistler and Vancouver. So at our games, like many Winter Olympics, we had alpine venues, that was Whistler, BC, and then city venues, curling, hockey, but also some snowboarding. So we needed to make sure that we had CT at those clinics. So we wanted to have CT and MR at both places. We do not want to use the public system. I think one of the messages here is that you need to know your sports. You need to be familiar with the sports that you are involved with in your athletes, and know the changes that are occurring in those sports so you can accommodate your medical care. We felt that we wanted to use ultrasound more. We'd seen an increase in Torino, and we thought that was warranted. We wanted to, for the first time in Olympic history, offer on-site field-of-play ultrasound. That had never been done before, bringing the imaging to the athlete instead of bringing the athlete to the imaging. Talk about that in just a minute. We knew that especially in Europe, there was a worldwide trend towards increased use of MSK ultrasound. We wanted to leverage that. There's also some cost savings, and you can, of course, do some nice work in intervention under ultrasound guidance that you can't do under MR. You know, IT is such a huge piece of imaging. So in previous Olympics, it had always been film or paper prints. There'd never been a filmless system before, so we were determined to have a completely filmless system and a paperless system as well as much as possible. We didn't succeed completely in the paperless system, but we did in the filmless system. We wanted to have the CDs of the images and the reports ready within 1 hour of finishing the study. That was our goal, because the athletes are on the move, right? They may be leaving the venues for another competition in another country before the Olympics are over, and they need to take the imaging with them. As you all know, athletes are vagabonds. You know, the professional elite athletes move around all over the world. They need to have their prior imaging studies with them. And in fact, these CDs are not the best answer. What we really need is a protected, password-protected server on which athletes can access their images and their physicians from anywhere in the world and be able to look at them at high resolution without having to plug in those CDs. You've all know what this is like. It won't launch for some reason. What's the problem? You're unfamiliar with how the template works. It's really a nuisance. So we have some work to do in making sure that athletes' prior imaging studies are readily available for them no matter where they are in the world. This is great for therapists, for chiropractors, for sports med docs, orthopedic surgeons, the whole team. We also wanted to have enhanced connectivity with academic centers. You know, you have athletes come in with weird things that aren't MSK related, like extrinsic allergic alveolitis, some lung disease. You need to be able to consult the expert to determine whether or not, who may be miles away, whether or not that athlete is fit enough to compete. So we had two villages, I mentioned. One was at Whistler, the Alpine venue, the other in Vancouver. This is a pretty nice day up there, probably nicer than it is right now. I show this picture just as a reminder that throughout all these hills, there's security. And you know, as somebody who does a lot of imaging for major events, you have to get used to that security. You have to work with it. It's part of being flexible. So there were 1,000 armed forces in the forest around the Olympic Village. The Olympic Village is the most secure place in the entire of all the Olympic venues. And so, you know, we'd run across them. We'd sometimes have to treat them. And if you happen to be skiing off-piste coming down here, you would very quickly be interrupted by a fellow with an automatic weapon saying, you know what, this is not where you should be. So very, very serious about security. Similarly, I'll show you this first. This is the map of the Polyclinic. The Polyclinic is just Olympic speak for the medical center. That's what they call it. So you can see lots of different rooms for examination and administration. The MR and CT were both portable. They're in trailers off either side of the medical center. Ultrasound, DR means just X-ray machines. Radiologist interpretation room, I'll get to that in a minute, very important. And then this thing called the MMU, the Mobile Medical Unit, which I'll speak about in just a second, which had a C-arm and an X-ray machine in there, a very important part of our clinic. But first, here's Vancouver. So, you know, again, just showing you the layout of the Olympic Village here. And then we have different problems with security. We don't have a ski hill, but we have water. So all this has to be, you know, rendered secure by all sorts of different police forces to make sure that the athletes are safe. So, based on what we knew about prior games and looking after other events, like we have an Indianapolis race in Vancouver, we looked after that for a while. We had looked after there's a lot of test events before the Olympics. There'll be alpine skiing, there'll be figure skating. We looked after all those. So we had some experience. We needed to plan what imaging equipment we needed in these two clinics. So for each of them, the clinics were mirrors of each other with respect to equipment. They were pretty well identical. One X-ray machine, digital radiography is what DR stands for. A high-end ultrasound machine with all the bells and whistles. CT, MR, of course. And again, don't worry about these abbreviations, but full-on IT. So PACS, which just means computer viewing, integrated information system. We use speech recognition because we had to get these reports out, as you recall, within an hour. So a lot of IT that's really, really important. And then there's this mobile medical unit. What was this about? Well, it turns out that if you apply for the Olympics, and it's probably very similar for other sports that are world events, you need to be able to have an OR to be able to do emergency surgery. Maybe that's cracking a chest. Maybe that's an epidural hematoma that needs to be evacuated. As a result, you need to have all those surgeons on call, cardiac surgeons, neurosurgeons, etc. But you also need to be able to have the OR, and Whistler did not have an OR. There's no OR in the hospital there. So you need not apply to the IOC for the Olympics unless you have an OR setting. So we had to get a portable one. So this is what we call the mobile medical unit. And inside this unit, which sits at the back of the Polyclinic, was a C-arm. Supposedly you can do two ORs simultaneously in there. I think that'd be extremely tight. But you can see there's plenty of room for one. Here's the C-arm with the images, and there's also an ultrasound machine, anesthesia, the whole bit. So now, fortunately, we never open the door to the ORs. But you have to plan for it. Planning at games like this is about the worst case scenario. We plan for dirty bomb attacks, plan for rock slides, bus crashes, terrorism attacks, everything. You have to prepare for everything. So this was the way we had hoped to manage multi-trauma. We also were able to deploy a MASH type setup with 100 beds around the Polyclinic in about 2 hours. So in case there was mass casualty, we could accommodate that. So this was a really important part. We used it as a triage center since we never actually had to open the OR door, but we treated our most acute people. Here's somebody being long lined in from a alpine ski crash. Basically what happens is in order to get people from the hill to the clinic fastest, you need to take them by chopper, and you need to take them on this long line. This is quite dangerous, but it's effective. So we could get somebody from the top of the downhill race course to the clinic in under 5 minutes, which can be life-saving. So very important to have that capability. Okay. So looking at the other, we've already covered all this. In the hockey venues, this is ice hockey, we had one X-ray unit and one C-arm. Again, the same idea, bringing the imaging to the athlete when as much as possible. And then this field of play ultrasound. So this had never been done before, taking portable ultrasounds to venues. We chose 5 venues where the forces on the musculotendinous unit would be the most explosive. Examples, of course, would be long and short track speed skating. Tremendous forces in the musculotendinous units there. Snowboarding, aerials for skiing. So we took these units there and we staffed them with a technologist, and the images were then relayed back to the Polyclinic, where they could be read by radiologists, and we would relay video loops, not just single images, because they can be not so graphic, the single images. You need to see the whole examination. And we were able to show that we could do that with a fairly straightforward local area network, a 1 megabyte local area network. So important information for the future. Now, of course, it might be that there'll be a sports med physician or someone else with an ultrasound machine at the venue. There's no need to send the images anywhere. That's fine. But we were just sort of experimenting with this new technology, which worked well. Here's a shot of our ultrasound technologist. We were using these laptop-style ultrasound machines. The handheld ones are not approved for MSK use as of yet. They're approved for obstetrical use and looking for free fluid, looking at the heart for pericardial effusions and right ventricular outflow and right atrial filling, that sort of thing. So these are not really ready for prime time in MSK world. They probably will be one day. But these work quite well. Good resolution. So what we found is that you can have all the greatest equipment in the world, but you need great people to operate the great equipment. So finding those people across Canada was a big challenge. We knew who some of them were, but they had to be available. When you volunteer for something like this, I think as many of you know, you don't get paid. You find your own way there. You likely won't get into any big events. So we have to make that clear from the outset. And you know what? That's the reality of it. We come to look after athletes. That's what's exciting about it. So it's just a picture of some of our teams. And we were able to get 19 radiologists from across Canada. They had to be trained in MSK and trained in multi-trauma because of the sliding center and Alpine. We had 51 technologists. This is tricky because GE was a worldwide sponsor for the Olympics. Excuse me. So it was all GE equipment. We had to have training centers across Canada to get the technologists up to speed on equipment that they may not use every day before the Olympics in a kind of just-in-time approach. And that was also quite challenging. So what do we end up with? Well, here you can see we did 879 exams. So that exceeded our predictions, about 55% more than Torino. Here's the timeline of the exams with the number of exams per day versus the date. So we find an uptick as people arrive with injuries that may have occurred at prior events, and they get imaged before the opening ceremonies. A lot of people go to the opening ceremonies, a bit of a dip, and then as the games go on, the numbers go up. So kind of a very similar to that graph we saw from Torino, but this is very helpful to know in terms of planning shifts. And so is this, the sort of time frame during one day as to when imaging occurs. So I also show this slide because we did do overnight exams. You need to have somebody on call. People get injured, and then the injury expresses itself perhaps at 2 in the morning, or gets worse, and you need to image those people. So we provided that service. We didn't do very many patients, but we did provide the service. And you can see, even at the peak time here on this day, the peak time was around 2 o'clock, we saw 81 patients. This is actually cumulative, 81 patients at 2 o'clock over the games. That's not that many patients for a day. In a busy hospital department, that would be nothing. But the difference is, I think this is very similar to what I've seen here at Aspetar. It's a fantastic model. That is, it's a team care approach. So in that radiology reporting room I was showing you, the radiologist would sit with the PACS monitors. If there are any priors, we review those. And then we review the study with the athlete, the coach, the trainer, the physio, sports med doc, orthopedic surgeon. So there'd be like 6 people in there, all going over the study. We were fortunate to have seen the mechanism, often on TV, which is a huge advantage to see the mechanism of injury. We had great history from the sports med docs who provided the team docs who were able to say prior injuries. So we were able to take our time, and this resulted in, even though it didn't seem like many exams, it was a pretty busy day. Here's the imaging exams broken down. X-ray, MR, ultrasound, CT, based on Salt Lake City, Torino, and Vancouver. You can see the increasing number of total exams. X-ray, fairly stable over the last 2 years. Look at MRI, a huge increase in MRI as MR becomes more mature in its ability to diagnose athletes at these events. Ultrasound, I think one of our failures at these games is we weren't able to get ultrasound up to the level we'd hoped. That is not that much of an increase over Torino. We would like to see ultrasound being used much more in the games. However, look at CT. 4 Salt Lake City, 2 exams in Torino, 86 in Vancouver. Suffice to say, we were very pleased we made the decision to have 2 dedicated CT units, one in Vancouver, one in Whistler, to deal with the increasingly severe injuries that occur at the Winter Olympics. You also see kind of different types of imaging findings, sometimes concentrated in sports that you weren't expecting. For instance, we saw 6 of these Morel-Lavallée lesions. What these are dehiscence types, degloving injuries, where tissues slide past each other in areas where the tissue composition differs. The classic place is up here at tension fascia lata as it goes over the greater trochanter here of the femur. Here's an image from the internet showing the hip joint, the greater trochanter, and then there's this mass out here. Well, this is our patient. This is, again, lateral, medial, superior, and inferior. And this is tension fascia lata here, and there's this big elliptical fluid collection. On another case, it could sometimes have fluid levels in it, indicating it's got blood in it. And this is the hemolymphatic mass, that is blood and lymphatic products, that occur when these small perforating vessels are sheared by the forces, in our case, particularly on alpine ski events. It was they want the surface on alpine skiing events to be rock hard. And as patients fall and slide, they get these type of injuries. So interesting, sort of a new description for a sport-specific athlete. Again, a reminder that we don't just look after athletes, although it made up almost half of our imaging tests. We also look after the workforce, all those volunteers, 27,000 of them. Spectators that are within the fence. As long as someone is within the fence, you have to look after them. That's our role. Olympic family as well, that's just part of the business. And, but athletes make up the most percentage. And if you look at the sports, again, this is highly useful for planning our approach, not just from imaging, but across the spectrum of sports imaging, sports medicine. See, alpine skiing once again had the most encounters. Ice hockey, snowboarding, this is pretty familiar. Freestyle skiing is fairly new. We saw more injuries there than we have in the past. The sliding center, well represented. And then good old curling down here, okay? There was one guy, thumb injury, maybe predictable in curling, but more people in the stands were injured in curling as they, were kind of trying to get up and down to their seats than were athletes. So there you go. Another thing that is true is that the community is very interested in what's going on inside the fence. Because security is very high, it's helpful for us to share some of that experience. So we were fortunate enough to have a blog. We had an Inside the Fence report from technologists and radiologists. All of us wrote 2 pieces each describing our experience, and this is very popular. People love to hear about what's going on, and otherwise it's just not that accessible. Quick word about London. London 2012, my colleagues Phil O'Connor and Andrew Granger were extensively involved in this, with Philip being my equivalent in London. Some differences, okay? Summer Olympics is 3 times as big as the Winter Olympics in terms of athletes. There's obviously different sports which have less likelihood of having multi-trauma type outcomes. So bearing that in mind, they had 2 ultrasound rooms and 2 MRs, including a 3T, which was great. Only 1 CT unit, which they didn't use that much because of the nature of the sports. Like any Olympics, you don't, as I mentioned earlier in the presentation, there are multiple venues that one uses. And so in the Summer Olympics, that's sailing and equestrian centers. And so what happens is teams bring their own ultrasound units, as you probably know. And team physicians will do their own ultrasound at the venues. And we saw that at Whistler as well. But look at the number of ultrasounds they did, 440. Now, sure, the Summer Olympics is larger, but that's still a great number, much bigger than Beijing. And they did see, just like we did with that Morel-Lavallée lesion, they did see some novel things. And this is great to write up in the literature and share with your colleagues. In things like judo and karate, they found there were more ulnar collateral ligament tears of the elbow than they expected. And that is because of sort of valgus force on the elbow, sort of not in a more chronic way like you'd get with javelin throwers or baseball pitchers, but more acutely, resulting in these tears. And again, they wrote that up, which is a useful addition to scientific literature. For the first time ever, ultrasound-guided interventional procedures were done. That's a first for the Olympics, an interesting initiative. And what about Rio in 2016? Well, we'll see. But Rio was fortunate to have some excellent data from London on which to plan their games. So what are the lessons learned? That was supposed to be my title. I better answer the question. Well, like any facility, service is number one, right? You've got to look after the patients. The reason you're there. We had something called the 1 meter rule. The director of our clinic was a military guy. So the clinic was run very, very carefully and well. And the idea was that if somebody was within a meter of you, you should try to help them solve their problem, or you should find somebody, take them to somebody who can. So we're trying to be very collaborative here. Flexibility is really important. When you're dealing with world events like this, the IOC could change their mind about something, and in 24 hours, you've got to be ready to respond. That's just the way it is. There are many factors you don't control, and you have to accept that and be flexible. Enthusiasm and spirit comes naturally, but it's a great thing to see. The morale in the clinic has got to be good. Everybody's there on their own time. They're not being paid. It's really important to make sure that's emphasized. And diagnostic imaging plays a central role in managing athletic injuries. I mean, here we were next to dentistry, the most common place athletes go. There are these scrums every day of clinicians and athletes and coaches and trainers. Great relationship with the therapists there. I would go over to therapy and see what was being done to one of the athletes whose images I'd reviewed with a therapist. So really, really great. And that teamwork was an essential portion, a part of looking after athletes. And anticipation, so getting that data, sharing it with others. Organization is so huge. You've got to, I started 5 years before the games, before the prior Winter Games had even been, played. Worked on it seriously probably for 3 years, and then took 3 months off during the course of the games. So that's pretty well what you have to do. I did write a chapter in Ali Gurmatzi's book, who I know a number of you know, a radiologist who's written a book called Imaging in Sports-Specific MSK Injury. My chapter is on how to prepare as an imaging department for a world athletic event. So that's coming in August. So I go into much more detail about human resources, equipment, and IT in that article. Hopefully it'll be useful for those that are faced with this. So, in conclusion, there's no question that MSK imaging is on the rise, and in particular, sports imaging is a new subspecialty, which is increasing in volume based on any one of a number of metrics. Imaging is playing this increasingly important role in the complicated decision about return to play, very much driven, of course, also with our clinical colleagues. Imaging has a chance to show itself as an important player in these professional and elite amateur sports. Certainly the equipment becoming more portable allows point of care imaging, which is really beneficial for the athlete. Make sure you know your sports. Radiologists need to understand the sports you're looking after, understand the biomechanics, the pathophysiology, and the equipment. And so, we're excited to be a new part of the team. And we need to recognize the value we bring. I think radiologists are guilty of not understanding that. And really leverage our availability and relationships with other sports practitioners. Not worry so much about who's going to do the exam. Make sure that whoever's doing the exam does a good job. And if we can help with that, then that's great. And teamwork is essential. And I put in here, just like Aspetar, I think this is a great model you have for care here of the athlete. So people ask me, was it worth it, after all this time? And absolutely it was. And it wasn't just because Canada won the gold medal in hockey. Okay, it was worth it from the point of view of care of the athlete. And we've come a long way from Salt Lake to Vancouver 2010. And certainly we've learned a lot. And it's so rewarding to be looking after athletes and helping them be healthy. And whether it's a weekend warrior or whether it's a elite amateur or professional, help them achieve their personal best or indeed set a world record. Thanks very much for your attention.